Today we're going to discuss something really important and something really common and something that I get asked about very, very often. It's the Hashimoto thyroiditis. So this will be the focus of our today's talk. Hashimoto thyroiditis is actually one of the most common causes of underfunctioning thyroid worldwide, especially in areas of the world that are iodine sufficient. And it is an autoimmune disorder. Some patients will have large thyroid and some patients would have rather atrophic thyroid. So there are two forms. Then what do we see under the microscope? We will see that within the thyroid gland there are lots of lymphocytes, and also we will see a destruction of thyroid follicles. How about the blood test? And the blood test is actually the way we make the diagnosis of Hashimoto thyroiditis. When we draw your blood, when we see high concentrations of TPO antibodies as well as thyroglobulin antibodies, we then can secure the diagnosis of Hashimoto thyroiditis. So let me give you a scenario that I encounter really frequently in the clinic is when we measure the antibodies, the patient has got TPO antibodies or thyroglobulin antibodies, and they have normal thyroid function. What is it? It is Hashimoto thyroiditis without underfunctioning thyroid. And those patients are more likely to develop underfunctioning thyroid than patients who do not have the antibodies and do not have the diagnosis of Hashimoto thyroiditis. The question then is, underfunctioning thyroid due to the Hashimoto thyroiditis reversible? The fact is, once you develop underfunctioning thyroid, it is indeed permanent in nearly all cases except in some children or postpartum women in whom it may be transient. The other question I get asked really frequently is, now that I know that I have Hashimoto thyroiditis, my thyroid function is normal, how and when will I actually develop underfunctioning thyroid? So we now know that if you have slightly increased TSH level and you have the antibodies, hypothyroidism occurs at the rate of approximately 5% per year. What are the causes of Hashimoto is, of course, many patients are interested about. So we know that there is a genetic susceptibility, meaning when there is a family history of Hashimoto thyroiditis, you are at increased risk of developing the disease as well. And also environmental factors play here a huge role, such as infection, such as stress, pregnancy, iodine intake and radiation exposure. This is what the science and evidence confirms. One really interesting thing that patients are always curious about is it because I have had a stressful time that I developed Hashimoto thyroiditis? What we know now and what the evidence confirms is that stress induces the suppression of immune suppression, and this is perhaps mediated through the effect of cortisol on immune cells, which then leads to immune hyperactivity, meaning your immune system goes in overdrive, and that presumably could cause Hashimoto thyroiditis. But there is no evidence currently linking emotional and psychological stress to Hashimoto thyroiditis. And why is that? It is because of the long natural history of the Hashimoto thyroiditis requiring actually a large part of the gland to be damaged before you developed underfunctioning thyroid, before your thyroid function is compromised, which is really interesting and something to keep in mind. So now I want to move on and give you a real life scenario so you can actually relate and extract information from this video that can apply to your daily life. Imagine Anna, a patient who saw me in the clinic. She's 28 years old and she would like to get pregnant. She has Hashimoto thyroiditis, is on L-thyroxine, her thyroid levels are perfectly fine and she feels well. So what shall she do? What is the first recommendation I give to any patients like that? She shall definitely contact us as soon as she knows she is pregnant. Soon as you have positive pregnancy test, call your endocrinologist to let them know that you have to come for a visit. The other question I get asked is, should I follow a gluten-free diet until I conceive? The possible benefits of gluten-free diet to improve your fertility or have impact on the autoantibodies have really been inconsistent and therefore are not the standard recommendation. Oftentimes I also get asked, oh, I've heard on the internet one could take desiccated thyroid hormone or T3 preparation for more energy, so I feel better before I try to get pregnant. And here is the thing, it's really crucial. There is no role for any T3 forms of thyroid hormone replacement, be it synthetic, being desiccated. All T3 preparation should not be used during pregnancy and also preconception. This is because your baby or the fetus is really reliant on the thyroid hormone for development, particularly for development of the brain. And the brain development starts as early at week 3 of the gestation, which means the brain of the baby starts developing already before most of us find out about the pregnancy. And here's the thing, the baby's or the fetal thyroid gland, it doesn't actually start to form until 11 to 12 weeks of pregnancy, meaning into your 3rd month of pregnancy, your baby does not have a thyroid gland. The thyroid gland remains mostly immature until the very end of the pregnancy. That means, of course, that the baby, the fetus, depends on your good availability of thyroid hormone. So you need a good thyroid hormone replacement for your baby. And that applies, of course, throughout the entire pregnancy. In fact, at birth, nearly half of the thyroid hormone concentrations in the cord blood are still from the mother. And here's the other thing that one should know. Once you're on the T3 preparation, the T3 preparation actually does not enter the blood-brain barrier at the fetus, at the baby. So meaning any maternal use, if you are put on T3 and you are pregnant, your baby's brain doesn't get any thyroid hormone because T3 doesn't cross the brain-blood barrier in the baby. So that means that T3 treatment is not able to supply the baby's brain adequately with thyroid hormone and is therefore absolutely contraindicated. Next question, which I get asked really frequently as well, is shall I start a daily supplement containing 150 micrograms of iodine? So here's the thing, in women with underfunctioning thyroid who is taking L-thyroxine and whose thyroid levels and TSH levels are perfectly fine, there is no need to supplement with additional iodine. I repeat once again, there is no need in that scenario to supplement with additional iodine. And here is why. The role of iodine supplementation, preconception, pregnancy and lactation is actually only to provide adequate thyroid hormone reserve to a woman without pre-existing underfunctioning thyroid, given the fact that she will require more upon confirmed pregnancy. So when you have Hashimoto thyroiditis, you're on L-thyroxine, you try to get pregnant, you are pregnant, you do not require extra iodine. Next question, shall I start selenium supplementation? The same applies to selenium as it does to gluten-free diet. The possible benefits of selenium supplementation to improve fertility are inconsistent, so we do not recommend it standardly. So bottom line here is, once you're pregnant, once you have a diagnosis of Hashimoto thyroiditis, when you're on L-thyroxine, once you fall pregnant, please contact your endocrinologist. And here's why. The requirement of your thyroid hormone increases throughout the pregnancy and it actually changes with each trimester. And many patients ask, why is that? Why suddenly do I need more L-thyroxine during pregnancy? Well, first of all, you need to supply yourself and you need to supply the baby as well, as mentioned before. Secondly, we know that there is nearly twofold higher serum thyroid binding globulin level, so basically the protein that binds the thyroid hormone during pregnancy because of the high estrogen levels, which leads to increased requirement of thyroid hormone. Secondly, which is very interesting as well, we know that placenta produces enzymes that actually degrade thyroid hormones T3 and T4. This is why you require more of it. And third, thirdly, there is also a higher volume for distribution due to increased plasma volume during pregnancy. So this is really crucial that you ring your endocrinologist once you're pregnant. You do not need to start iodine supplementation if you're taking L-thyroxine and have Hashimoto thyroiditis. We do not recommend additional selenium or gluten-free diet, and we definitely do not recommend, and it's absolutely contraindicated, to take T3 during pregnancy. I hope this has been really helpful to you. This is a very common topic I get asked really frequently. Follow it and share it with your friends, and follow for more helpful videos with evidence-based endocrinology facts.